right. Well, hello, everybody. Welcome to the Crisis Jam. I'm Lindsay Browning, the Director of Medicaid Programming at the National Association of Medicaid Directors, and I'm delighted to be back as your host for today. We have a fabulous featured presentation lined up with Damali Alston and Kate Peterson, who are going to share about one local managed care entity's approach to meet community crisis needs. So really thrilled to hear from them a little bit later in the episode. Before we get to that, though, we always like to start with a couple of things to know, things on the radar. And the first one, if you joined us early, you got a preview of this question, but we want to ask the group, and please drop your thoughts into the chat, what you think Governing Magazine identified as the top 5 social issues to watch in 2024. I'll give you a hint that we wouldn't be asking this as a teaser if there wasn't some connection to the work we all are doing here, but would encourage you all just to drop those thoughts into the chat. And we'll reveal the answers later. So go ahead and give your thoughts on what you think the top 5 social issues Governing identified are. Just a reminder, you can access all the resources from the Crisis Jam on talk.crisisnow.com. That's where you can sign up for the newsletter. That's where you can register for the Crisis Jam. And again, a reminder that everybody should get their own individual link for the Crisis Jam rather than sharing those links. That helps keep the space safe and secure. And again, you can watch some of the videos there and check out articles and resources. As a reminder, we're always looking for new ideas for featured presentations. We've had 400 unique speakers since the Crisis Jam launched in 2020, and we're always looking for your ideas about who would be a good featured presentation for this room. Next slide. And you can see here just some of the folks that have done it to date. We want to share a couple of news items with the group, as always. The first one is a Washington Post article, actually a series of articles that have featured some recent action in DC, some legal action from community organizations about police response to individuals in mental health crisis care. I think the articles explore that while there have been progress to build the crisis response system, that there's simply not enough capacity, and police continue to be a predominant responder to mental health crises. So it looks at some of the legal challenges, legal action emerging there. Next slide. We also want to give a quick shout out to the NAMI Reimagine Crisis newsletter, which is where we lifted this piece from. But there's a great synopsis in there of some legislation that Representative Tina Orwell, who I know is a regular contributor to the Crisis Jam, so the legislation that Representative Orwell has introduced in the House passed actually in Washington State, that would recognize crisis responders and the need to safeguard them from civil liability. So we have a short video to share of Representative Orwell talking about this legislation.
The bill in front of you is really about providing protections and tools for people working in behavioral health to help those in need in our community. You know, with 988, we have this incredible chance to redo our crisis system. And we know that there's a place to call, which is 988. And now we're working on someone to respond and a place to go. And so when people call 988, about 95% are resolved on the phone, but about 5% need a mobile response. And we want to make sure that those clinical teams that are going out are protected because it is difficult work. And we're asking a lot of people to go out rapidly and to go into a lot of different situations. And so again, we provide these kind of protections to other people to do this line of work, and we'd like to extend it to people doing behavioral health, because at the end of the day, we want people to get the services that they need and deserve. Urge your support.
So really interesting to see that action, and curious from others across the country if that type of legislation is being debated or proposed in your states. Would love to hear about it. So please drop that in the chat. We want to flag some upcoming events, particularly if you don't already have plans for the summer and you are part of this Crisis Jam community. You are invited to join the Crisis Now Global Summit in Amsterdam, June 29th through 30th, 2024. So this summer, this will be the third one that has been done. It's really just a phenomenal event. So mark your calendars, plan to join for that. If you do already have plans to travel to Europe this summer, maybe you're going to the Zero Suicide event in Liverpool or the other match opportunities happening in late June, you can tack on the Global Leadership, the Crisis Now Summit onto those events and join in the Netherlands as well. So if you have questions about that, you can ask Karen and the team at RI International, but I hope folks will join us for that great event. All right, now we are going to go to the trivia hot seat. I'm going to invite Chris Santasaro to join us. Chris, I think this is your first time being in the trivia hot seat. Just you want to tell us a little bit about who you are, and then we'll get into the question?
Sure, absolutely. Thank you, Lindsay, and thank you for inviting me. My name is Chris Santasaro. I'm with Connections Health Solutions. I'm our Vice President of Government Affairs, and in that role, I have the privilege of advocating at all levels of government, literally for our model of care. That's 24 hours, no wrong door approach to crisis stabilization and observation. So excited to be here today. It's been an honor to be a part of this group. One of the first things as I started with Connections and been around the country traveling in this field, as I've heard about the Crisis Jam and how what a wonderful resource it is for everyone in this field and this vocation and the great work that everyone does. So look forward to the question today, being in the hot seat, and also look forward working with everyone here to advance our call as we work to build out 988. Thank you.
Wonderful. Well, thanks for being in the hot seat. Here is the question we've got for you. In Crisis Jam episode 36, the co-founder of Connections Health Solutions, Dr. Chris Carson, described crisis facilities that served everyone. So our question is, which of the following did Dr. Carson state was needed to start effective crisis care in a facility? Option A is prior medical clearance in a hospital ED. Option B is submission of a referral information packet. Option C is report of blood alcohol level if intoxicated. And option D is ring the doorbell. So we've got a phone a friend. You can phone a friend if you want. We've got the poll of the audience open right now. But any initial thoughts as people are giving their input?
This is what I love the most, and I don't want to prejudice the poll right now, but this is one of the wonderful things that makes my job easy, quite frankly, other than, obviously having Dr. Carson, also Dr. Balfour, I'm sure everyone on the call knows. But this is what I'm most proud of in advocating at all levels of government for. It seems unthinkable, but it's true. So I'll let the poll continue on. Thank you, David, if he's on for the layup. I thought he was going to really try to stump me here, but this one's pretty easy, and why I love being at Connections, being a part of the crisis movement, and advancing our model for everyone's benefit throughout the country. So when the poll's finished, I'm curious. I'd like to to see what the results are, but then I'll I'm glad. So yeah, it's literally, I'll officially say D. And for the 9% and 6%, I just want to say those are typically the things we get asked when we're first trying to enter a community, is, the hoops and ladders, unfortunately, that folks face when they're trying to build out a crisis system or when they need help. And I think that's sadly the situation a lot of communities are in, where they need medical clearance because the providers need to be safe in caring for those individuals. And they do require, other providers require medical clearance. Other times in healthcare, if you need a knee surgery, heart, they want to look at the packet, the healthcare packet, the referral packet, or they want them to be screened for their blood alcohol, other substance use things, because they're a mental health clinic not a substance abuse clinic, and vice versa. And they kind of folks unfortunately get ping-ponged around. So, you know, the wonderful thing about our model and about a lot of the great crisis providers out there, a true no wrong door model, is ring the doorbell. The clinicians, the IDT will be there to help you, help that individual get care quickly, get treatment quickly, stabilize the individual, de-escalate the crisis, and then kind of connect to, you know, community-based services post crisis. So thanks for that. I think official. I think it's official, but you know, D is my answer, and it's just, you know, great showcase of the work that a lot of the great crisis providers in the country do. So thank you.
Yeah, thanks, Chris. And I suspect you won't be so lucky next time you're in the hot seat.
Yeah.
It's probably going to throw you a trick question, but really appreciate you doing it.
Thank you.
All right. So let's go ahead and move back to this question of Governing Magazine and what are the top 5 social issues to watch in 2024. Some of the things we heard were democracy. I think there was a piece around mental health access to treatment, but let's go ahead and see what the answers are. So the 5 here are crime, fentanyl, immigration, mental health, and poverty. For those who are early, you may have seen that Ruben got it right. Ruben, I think you looked it up, but that's okay. But these are the 5 that they raise as the areas where lawmakers will be focused on kind of these social issues this year. So probably resonates with a lot of folks here. All right, so let's go ahead and turn now to our featured presentation. Really thrilled to welcome Kate Peterson, who is the Director of Healthcare Network Project Management at Alliance, and Damali Alston, who is the Senior Director of Provider Network Evaluation at Alliance. I'm really excited to hear about the great work you guys are doing in North Carolina, so I'll turn it to you.
Great, thank you. Thanks for having us. Really appreciate being here. So just a couple of things. Want to talk a little bit about who we are. So we are a managed care organization, and we cover now 7 counties as of February 1st. And you can see us in that kind of peachy, kind of darker reddish color. And as you notice, we're a little bit disconnected. We've got 1 county down at the southern part of the state, and then we have the rest all kind of in a little grouping there in the middle part of the state. We cover mostly urban areas, and so all of our counties are pretty urban in nature, and we cover 2 of the largest in population, Mecklenburg and Wake County, where Charlotte, North Carolina, and Raleigh is. And together we have a population in those 7 counties of about 3.5 million. So although we have a small number, we have a lot of people. And so we cover those counties for Medicaid, and today it's behavioral health. We will be moving into a tailored plan, which will mean we'll manage behavioral health and physical health care to provide whole person health at some point here in the near future, potentially July. And just historically, we became a managed care organization in 2013. So that gives you a little background about us. Go ahead to the next slide. All right, so where we started in 2013 is we covered 4 counties, and we had 3 facility-based crisis programs, Wake, Cumberland, and Durham. We covered also Johnston County, which is just south of Wake County, and where Raleigh is. We had mobile crisis teams, and we used emergency rooms a lot. So we really were overusing emergency departments. We were seeing long lengths of stays in our facilities, very limited throughput, lack of dedicated space for children and adults who happen to be doing assessments in those facilities. And so it was a pretty big challenge for us as a newly started managed care organization. You can go ahead to the next slide. So again, we weren't really happy with where we were. So fast forward, now we're a couple of years old. And we saw our programs as having no real core model, long lengths of stay, long EMS and law enforcement drop-off times. And one thing I didn't put on the slide, but is true, we had a lot of diversions, meaning the facilities were full. They ended up turning people away. And we certainly didn't want that. We wanted a model that conformed with, at that time, SAMHSA's published core elements. And we really wanted a more of a recovery orientation and peer support infused. Go ahead, next slide. So we actually went across the state. I looked at every program. Our board reviewed a matrix of what was going on across the state. We looked at national models, and we decided we were going to issue a RFP. We were going to transition one of our longest standing programs, and RI International got that basically because there were several elements that they used in programming that we really wanted. Nowhere on door, peer support, and we really wanted to focus our work. And you'll see here a picture of Durham, and I know that we'll talk about that a little bit later too. But that was the first facility we actually started really looking at models for. You can go to the next slide, please. All right, Jamali, I'm turning it to you.
Okay, so, with RI taking over the Durham facility, we really did shift to a model that used their kind of living room and retreat approach for 24/7 behavioral health urgent care services. We immediately saw and continue to realize shorter lengths of stay and drop-off times for our law enforcement. We no longer have, law enforcement sitting with members for 30 minutes, an hour or longer while they're waiting for them to enter in through triage and assessment and into the behavioral health urgent care with RI. It literally is down to, I believe it's like less than 15 minutes. They have a quick drop off so that law enforcement can get back out in the community and they're not continuing that presence and that setting with our members, so that they can really get into more of a peer-based and clinically appropriate setting without kind of that involvement of law enforcement also hanging over them. One of the other things we also wanted to look at was we continue, even though we had this amazing program, we continue to have concerns with the inappropriate use of our emergency rooms for folks in behavioral health crisis, but we're not rising to the level of a harm to self or others type of crisis needing an inpatient admission. And so we started looking at the concept of behavioral health urgent care programs that are very similar to your medical model of urgent care, where you go, they assess your kind of what's your immediate crisis at the moment. You don't get a full health screening, so to speak, but they're addressing, you're showing up with flu symptoms. They're going to test you for flu, make sure, they may test you for a couple of other different things and then treat you and send you on your way. And so we did develop programming in 2 of our counties, in Durham and then a year or so later in Wake County, with 2 of our behavioral health providers to stand up this behavioral health urgent care concept, so that folks could use that as an alternative to emergency room use when their crisis was not to the level of self-harm or harm to self or to others. Next slide.
All right, so 2018 also, we started the development of a facility for children and families that provided a 24/7 urgent care and facility-based crisis. We purchased an old hospital, we've renovated that, and it had mold, asbestos, and lots of other really fun stuff from the 60s and 70s. So it took a very long time, and you see a picture of it. We are open for the urgent care and soon to be open for the facility-based beds. This model was basically when we started talking about it, and our board looked at us when we did the research on the adult models. We said, we've got another issue here. Why are we having children and families present in the same spaces as we do adults? And we're not focused, and we're not really looking at the needs of both populations. So we ended up getting a grant from the state for the $1 million, which helped us purchase the facility. Underwent a lot of renovation, as I said, and here you are. So we do have this program now. Very excited. I think it's one of the only ones that has walk-in assessment capability 24/7. And we are very pleased that we added this to the array. The only regret we have is not having it ready in 2020, as you can imagine. All right, next slide. So where we are now, and this has been a long road for us, figuring out what our community needs, how we need to structure ourselves, what kinds of things we need to be developing to fill the gaps in our continuum. So we have shifted models, and we're working with RI and a couple other facilities. We have opened that crisis center for children. We've extended the behavioral health urgent care hours beyond where we started in 2018. We're also looking at ways to do mobile crisis. Mobile crisis in North Carolina is still under Medicaid as a fee for service program service, and we're struggling with that. And so we're exploring ways to make it more of a firehouse model, figuring out how we can fund that, and that's really where we want to be. So although we're not there right today, that's where we want to go. We've developed mobile outreach, response, engagement, stabilization. That is based on New Jersey's MRSS model, and we have teams in all of our counties, and it serves children and families using peers on the team. And that's been actually a newer addition to our crisis services, and we've really ramped that up in 2021, 2022. So we're very, very excited about that. We've had some really early successes, keeping kids out of the hospital, and certainly keeping kids from our Department of Social Services offices, which is happening way more than we want. And then, of course, we've still got, and we've continually had robust CIT, community partnerships and supports, and we are very present in every community. All right, next slide. So we also have our crisis stabilization and transition programs, which is small residential homes for youth that are either being boarded in emergency rooms or in Department of Social Services office. So we created rapid admission, and we created several programs across our catchment to serve these kids. And that's been certainly a challenge, but it has really, really helped our system with having fewer kids in those kinds of settings, in boarding and EDs. And offices are no place for kids. I mean, we have really worked hard to get them out of there. And I look at Mecklenburg County, where Charlotte is. They joined us in late 2021 and had a very long list of kids in custody. And we saw those kids hitting that office quite regularly. And that has changed significantly over the last 2 years. We also have worked with an organization for a service called Therapeutic Relief, which can be deployed for kids in services where they have a real high risk of disruption. So we can provide one-on-one for those kids. We can also do it as part of a service we can do with kids that are boarding at DSS offices inappropriately, until we can get them settled in a longer-term situation. We've created an other 24/7 behavioral health urgent care with the Steve Smith Family Foundation. It's in Charlotte, and it does serve adult and children, but it also has dedicated space for either. We opened that, and that has been at this point the only urgent care in the Charlotte area, which is again one of our largest areas at probably around 1.2 million people. We also again developed those MORS teams to really they respond for whatever reason the caregiver calls. So they will respond face to face. They can work with stabilization up to 8 weeks and to connect to services. The family peers on the team are really, really critical. And all of our teams do have family peers. My next step there is to add youth peers to those teams as well. We've, created the facility-based crisis, which isn't quite open yet, but we're getting there. And then, of course, we actually really patterned this continuum in children and families after the national guidelines. So we've got our crisis call centers, and someone to respond in a safe place to be. That was our goal. So we're really hitting on all three of those at this point in time. Next slide.
Okay, so we also have had a couple of pilots going and support. There are 2 co-responder models in Wake County and in Mecklenburg County, and that's where we're pairing mobile crisis staff with EMS staff or with police departments, so that as those either EMS or police departments are responding to behavioral health emergencies, instead of those, being transported directly to an ED, so to speak, those mobile crisis teams can intervene and work to help stabilize and maintain individuals in the community and link them to additional behavioral health resources. And we have seen early successes with those as well. We have had community paramedic programs and continue to have those in Durham and Wake counties. That's similar to CIT in that the paramedics are trained in behavioral health interventions. And so they're not quite kind of that co-embedded EMS and mobile crisis, but they are first responders that have training in behavioral health crisis intervention. We also have Peer Respite and Recovery Hub under development in Wake County. We're working with an agency, PRN, who has those programs in Mecklenburg County, and we are funding them to establish those services in Wake County as well. The Peer Respite program provides up to 3 to 6 guests a place they can stay for 10 days or longer. And it's accessible to anyone with or without insurance and without the need for an assessment, authorization, or referrals. It's not part of the standard kind of MCO utilization review, right? It's a peer-run respite facility. They can be used as emergency department diversion, as a planned or unplanned stay, or for someone that's transitioning out of inpatient services back into the community. And for individuals in the ED that are not in need of inpatient stays, but need the additional support. They are also establishing a recovery hub that provides a safe and recovery-oriented, peer-run, trauma-informed community setting for individuals with mental illness to access peer support and social connections. And that facility also, or that program also supports the individuals that are in the peer respite program. Of course, we, have the 98 line, in North Carolina and all of our counties, and the peer warm line through PRN as well. Next slide.
So let's talk about some of the challenges and opportunities we have before us. One thing that I didn't say about North Carolina is, as we are developing this tailored plan, we also have standard plans, which are health plans that are serving folks for more of your lower level behavioral health needs, outpatient, med management, etc. They do have a crisis continuum. And I think one of the challenges is infusing the crisis continuum and making it standardized for all payers, not just us. So as a quasi-governmental organization. So we'd like to see more investments across the entire state with across the entire payer system. We also, want to see more supports before crisis. We want to see respite. We would like to see more of the programs like the MRSS model, where we can get people before it's an acute situation. We also want to fund Firehouse Mobile Crisis. We've talked about that. We really see the need to be available in NC for that. And I see a lot of questions, which I'm looking forward to getting to. And of course, one of the biggest challenges we have is funding and time to develop. I've been very fortunate that I have a team of 4 that work with me, and we are charged with managing the projects to fill the gaps. And it is a challenge to stay on top of all the things we really want to do. So that's funding and time is a lot of the challenge that we will continue to face. All right. I think we can get to the chat and some questions.
Wonderful. Well, let's see if we can get to these questions before we turn to our roundtable. The first question is around whether the facilities accept individuals with intellectual and developmental disabilities, including autism. I know there's been a lot of conversation around making sure, crisis care, behavioral health systems have capacity to serve those individuals. So just curious if you can say anything about that.
Let me talk about the children's side of that first. On the children's side, on our child facility-based crisis, we actually have some sensory-friendly rooms, and we intentionally developed the facility and selected the provider for being able to serve children with IDD and autism.
Our Valley Thrive.
So that was very exciting. The other thing that we have been doing is in those crisis stabilization homes is we've created a couple of those that specialize in co-occurring disorders so that we can definitely serve those kids. On the adult side, it's less clear, I think. I think that we are going to serve people no matter what coming in the front door, but we're going to try and get them to the right type of treatment. And that has been a challenge. Damali, do you have anything to add on that?
Not, facility side. I think all of our facilities, because of their crisis in nature, are going to accept, members as they come in. But I think that is that challenge, right? Once you stabilize, the initial crisis is really ensuring that you're linking to appropriate services to meet their needs. And so that can, within a crisis facility, that can be, I think, difficult at times for folks with an IDD, a co-occurring disorder. And so I think that's always a challenge, but something that all of our facilities are also, trying to work to overcome. I know that on the mobile crisis side, we intentionally are ensuring that all of our IDD behavioral health providers have contracts or memorandums of agreements with mobile crisis teams in each county. So they do have that level of support within mobile crisis to be able to respond appropriately and have the clinical support for our IDD members.
Yeah, and I would just add one more thing is that one of the things that's a project on my team's list and hasn't launched yet, but is actually some direct service personnel training, and one of the curricula is around crisis response. So for our IDD providers.
Great. I know we're coming up on time, so maybe I'll just ask for a super fast response to the second question. Anything you can share quickly around interoperability, kind of data exchange in your all's work?
No HIE yet in North Carolina. And so that is a huge challenge. We have systems still that don't talk to each other. And so I think for us, that's still another challenge that we need to continually work on, and data sharing obvious agreements are difficult.
Yeah. Yep. Well, thank you both so much for sharing about your incredible work. Really fascinating to hear kind of how you guys are building out the crisis care continuum. I want to shift to Joy Brunson, Nusugaba, who's the Chief Operating Officer of Recovery Innovations, Inc. And Joy, would love to just hear your reflections on the presentation we heard today.
Absolutely, absolutely. Thanks for having me. I've had the pleasure of working with the Alliance team since 2015 when we started the Durham program, and I think my reflections on what they have presented really just showcases their diligence to wanting to be very evidence-based. That was one of the important pieces when we moved into operating the Durham facility with them. That's when in North Carolina, Recovery Innovations transitioned from a more rural approach with our crisis facility to urban area. And so one of the things that we have been working with them very diligently on, specifically in Durham, is all of the ideas around how to make sure that we are working with the population we have and in the community. And so we've piloted so many ideas and projects along with the Alliance team, as well as the communities there, to ensure that we are providing the services that are needed. Some of them have worked really well, including the implementation of MAT in the crisis facility, and some others we found that it was better to partner with some of our community partners. Just looking at their slides, I think it just showcases the whole continuum and then the continued ideas. We have not gotten to the end of or a perfect system, but continue to improve upon it. And so, like I said, we worked with the Alliance team since 2015, starting the Durham program in worked with them since 2015, started it in 2016, and we continue to look forward to continuing to work with them on all of the new ideas and evidence-based practices.
I love that reflection of, reflecting how far the system has come, right? How much work you guys have done, but still the opportunity to continue evolving and learning and addressing gaps and building those evidence-based practices. So really appreciate that. Thank you, Joy, for those reflections. I want to go ahead and shift us now to our standing updates for the Crisis Jam. And we're going to hear first from SAMHSA. So I'm going to turn it over to Richard McKeon.
Hi, thank you. Can you hear me okay?
Yep.
Great. So I wanted to let folks know about several convenings and pieces of work that are coming up. This coming Friday, we are hosting a convening with fire and emergency medical services. And we are looking forward to that. It's modeled after one that we similarly did around law enforcement in coordination with the Department of Justice last year. And I only learned, over the last couple of years about the deep interconnectedness between fire and EMS, and which was an important piece of understanding the overall system. Also related to this area of coordination with 911 public safety answering points and emergency medical services, there are two pieces of work ongoing. SAMHSA's Mental Health Policy Lab is coordinating an effort focusing on when 911 versus 988 should be contacted. That is something that should be finished later this year. And Vibrant Emotional Health is also working around liability issues in 988 and 911 interactions, which I think the relevance of the proposed law in the state of Washington is of great interest, given that. Second, in the beginning of April, SAMHSA is sponsoring a policy academy, I believe it's for 6 states, on crisis systems design. And obviously, SAMHSA have been promoting the model that's in our national guidelines. Well, this is a policy academy to help states who are really wanting to do some design or redesign work along with subject matter experts and others. And then finally, in the beginning of May, we are sponsoring a 988 grantee meeting. This is a grantee meeting for the, I think it's 54 states and territories who receive SAMHSA's 988 grants. Our tribal 988 grants, our crisis center follow-up grants, as well, of course, as Vibrant. And so we are anticipating widespread participation across the entire 988 call center world. So this will be the first meeting of its kind. We did have 2 meetings over the last 15 years, which were all call center meetings that SAMHSA held, one in New Orleans in 2007, then another one in Baltimore that was around 2014. But this is the first time we've been able to do something like this since 988, and we couldn't be more excited about it. So that's what I have. Thanks for the opportunity.
Wonderful. Thank you, Richard. Sounds like a lot of exciting work going on, and especially convening folks around these issues. I'm going to turn it now to Wendy Morris at NASHPID for the NASHPID update. Wendy?
Great. Thank you so much. It's great to be here today. So I just have a couple quick updates, and one is actually just a quick update on the Link Center, which was featured in episode number 157 just last month. But I'd love that this issue of serving folks with co-occurring mental illness and intellectual and developmental disabilities came up during our feature presentation, and there was some conversation about that because that's exactly what the Link Center is doing. It's a 5-year cooperative agreement with the Administration for Community Living to develop a national resource center to really build the capacity to do that work, to really better serve people with co-occurring disorders. It's led by 3 associations. NASD is the National Association for State Disability, Developmental Disability Directors, NASHPID, and then NAD, the National Association for Dual Diagnosis. Plus, we have multiple other partners to help us focus on diversity, equity, inclusion, as well as continuous quality improvement. We have a steering committee exclusively made up of people of lived experience. And our goals, there's 3: realize system change, develop clinical capacity, and improve service access. And we're doing that by engaging with expert contributors, learning from our steering committee, and then just identifying information, resources, trainings, and gaps. But the piece this audience is probably most interested in is another policy academy. This is different than the one that Richard spoke of, but it is a collaboration with SAMHSA, and we also invited 6 states to work with the Link Center to really build that 988 and crisis response system for folks who have co-occurring mental illness and IDD. So super excited. We had our kickoff. The formal announcement about the 6 states is yet to come, but we already had our first kickoff meeting. These states have some fantastic ideas, and they're going to do some great work, and we're going to be excited to bring back to you a lot of those lessons learned and what other states can follow. So I will put in the chat that episode 157, as well as there's an email. If you have further questions, you can email me or the Link Center. The second update I wanted to just give was on NASHPID's Behavioral Health Workforce Resource Guide. I think we've talked about it in updates in the past, but we just released the 3rd version of that update. I'll put that link in the chat as well. The audience is really for state mental health authorities, but I think a wider audience would probably benefit from it as well. It's got a ton of examples about work folks are doing to build their workforce capacity across the states and territories. So just all kinds of examples of what's being done and how it's working. We did seek out updates and outcomes from previous projects for this version, and it's very clearly marked what's new. So if you've read it before, it'll be easy to find what's been updated and what's been added. And this workforce guide, if you haven't seen it, it follows a framework developed by the National Conference of State Legislators, really trying to help us have a common language. And there's 5 key categories: understanding workforce needs, increasing the supply, expanding reach, addressing distribution, and then retention. And again, if you have questions or if you'd like to contribute to the 2025 version, we would love to hear from you, and I will put my email in the chat. Thank you.
Thank you so much, Wendy. All right, now we're going to turn to my favorite topic, because this is the world I live and breathe in, but our Medicaid segment. So invite Tom Betlach, who is a partner at Spire Healthcare Strategies, to join us. Tom is a former Medicaid director and former budget director in Arizona. So Tom, take it away.
Lindsay, how are you? Great to see you.
Good to see you too.
Thanks for having me today. You know, we've had these segments monthly, really just to highlight how can Medicaid come along and help support the crisis system. And during these segments, we've heard from a number of different states. It was great to see the presentation from the Alliance today in terms of really highlighting how progress is incremental in terms of these large delivery system changes that they've been driving towards in North Carolina. So just wonderful to hear that. Last month, we talked about a New Year's resolution of let's engage Medicaid, let's bring Medicaid to the table to see how we can advance crisis systems in our state. And this month, we thought it would be great to leverage all the subject matter expertise on this call and really get some feedback in terms of where you think in your world Medicaid can come along and help support crisis system development and evolution in your state. And so for that, we have a question that we'd like to put up and get your feedback on. And you can reply in terms of checking multiple boxes here, but we want to really hear from you all in terms of how you view the Medicaid organization in your state as a partner in terms of accomplishing different things to help support the crisis system. So the first area is financing, the bank of Medicaid. Obviously, Medicaid has access to resources through its structure and programs, and Medicaid's involved in setting rates and identifying covered services and populations. But at the end of the day, Medicaid can help deliver financing around the sustainability of the crisis system. The second is leveraging the delivery system. So we heard about the Alliance and the managed care structure in North Carolina, or is it a fee-for-service structure? So how can Medicaid, or is Medicaid a partner that you can go to really help think through how you're going to leverage the delivery system design in your state in terms of contracting requirements, performance expectations, who the providers are that can participate in this? The third option is to assist with stakeholder facilitation and convening. You know, we heard from Dr. Richard in terms of all the work that SAMHSA is doing to convene partners. Medicaid can also serve in that capacity to bring in providers, stakeholders, law enforcement organizations. And we're just curious if that's something you view as an opportunity to partner with your Medicaid organization on. The fourth area is technical support with CMS. So there's a lot of rules involved in terms of being able to have access to financing streams. And the Medicaid agency is in a place to help in terms of advance. We heard about mobile response earlier and the ability to get the state plan amendments through, and all the other technical issues are involved in terms of the world of Medicaid and being able to be a technical partner on that front. The fifth area is subject matter expertise. Now, we recognize in many states, this oftentimes comes from a separate organization that's responsible for behavioral health, but there may be some expertise in your Medicaid agency. And so do you view Medicaid as a source of being able to go to in terms of having some area of subject matter expertise? And then the last area that we hope doesn't get checked, but we just wanted to offer it, is none of the above. And so just trying to get an understanding of if there are states or you view your Medicaid organization as not being able to help you partner with any of these. And then of course you can identify an other that we'd love to hear about in the chat if you want to identify another area that you feel Medicaid could be a critical partner in terms of providing some other service. So with that, you know, if we can just tabulate the responses, we'd love to see sort of what this group thinks in terms of where Medicaid can help support. So 56% financing, how to leverage the delivery system, almost half again, assist with stakeholders facilitation, a third, technical support. So if you have technical issues, hopefully you view your Medicaid agency as a conduit to being able to help resolve some of those issues with CMS. They certainly serve in that capacity. Subject matter expertise, it's actually a higher percentage than I thought. And so Lindsay, I'm not sure if you have any responses to this, given where you sit and this is your everyday work in looking at these results.
Yeah, I think this is fascinating and just really appreciate folks, including multiple of these options. I think something we often hear a lot from Medicaid folks is that they can be really helpful in sort of the delivery system design pieces. And it's valuable to have them at the table early because they may run into barriers around financing if some of those technical considerations of what federal policy allows weren't considered at the outset. So I think the bottom line here that I would reiterate is engaging your Medicaid partners early around this work is key, and financing is a huge opportunity, but there are certainly other places where they can be a fabulous partner.
Well said. Couldn't have said it better myself, Lindsay. So hopefully folks are taking that New Year's resolution to heart to engage Medicaid, and here's some opportunities that you can be thinking about in terms of how to do that early and often. So with that, we'll turn it back to you, Lindsay. Thanks for the opportunity.
Wonderful. Thank you so much, Tom. All right. I want to turn it over to Stephanie for our legislative updates. Stephanie?
Yeah, thank you so much, Lindsay. Good to be with you folks. So with it being late February, we are just about at the halfway point for most states whose legislatures are meeting this year. I certainly won't touch on everything, but just a few highlights for you, starting in the state of Florida. You may have seen news of Senate Bill 7016. This is called the Live Healthy Act. This is a very broad healthcare package, really focused on the healthcare workforce, but most relevant for this group. There are some great provisions in there to improve and expand mobile crisis response in the state. Specifically, it creates standards for mobile crisis teams, such as, just an example, requiring a response within 60 minutes. It requires the state's Medicaid agency to seek coverage and reimbursement for mobile crisis. So that pairs very well with what Tom was just saying, and also just requiring them to maximize federal funding for mobile crisis response. And then there's direct funding in this too, $11.5 million that will reoccur each year to enhance mobile crisis teams and ensure coverage in every county. And the really exciting part is this has already passed both chambers. This is just awaiting the governor's signature at this point. A few other states I wanted to highlight. Vermont right now is actually considering a 988 telecommunications fee bill. It's a 70-cent fee, but that would actually go towards multiple purposes. I will say Vermont has a very unique telecommunications fee structure, so this bill is structured a little differently. But that is also moving through the process, as is Maryland has a 988 fee bill, and that will actually have its first hearing kicking off in just a few minutes, I think. And I know we had that great clip from Washington State at the top of the call. One other Washington bill worth mentioning real quick is Senate Bill 5853. This has made it halfway, well, more than halfway through the process. It's passed the Senate, it's through its House committees, just needs a floor vote. And what this does, and it extends Washington's 23-hour crisis relief center model to people who are under 18. And of course, if you are kind of interested in doing deeper dives on any of the bills I've mentioned or any of the bills pending in our tracker, just a reminder to be sure to join our 98 state advocacy calls that are once a month, first Monday of every month. So we have one coming up this Monday. And I'll put my contact information in the chat if you want to join those.
Wonderful. Thank you so much. Now I want to shift to our crisis talk and invite Stephanie Hepburn to join us, the editor-in-chief of Crisis Talk, and Ron Phillips, who this week's article focuses on. So Stephanie? Stephanie, you're on mute. Sorry.
Yeah, thank you. Thanks for letting me know. Yes, so I'm happy Ron is here. He's the Chief Nursing Officer at East Tennessee Children's Hospital. And Ron, when we spoke, you told me that behavioral health visits in your emergency room have been on the rise, and partnering with McNabb has helped. You specifically talked about two innovations that we've mentioned before, actually, in the JAM. But it's great to get your perspective and your lens on the innovations. Could you share what those were? And also, what are kids struggling with in your emergency room when it comes to behavioral health?
I'll start with the second question first, because for whatever reason, we know what the reason appears to be. We will have our busiest February ever in our ED. And it spikes this time of year every year, right around Valentine's Day. And we'll see a spike in our teenagers. Well, we did see a little bit of an increase. It's a little bit early to measure, but they just announced in the last 3 weeks a new part in Tennessee where they will hold kids back in 4th grade if they haven't passed their 3rd grade exam. So that's where we saw a spike last year. So both of those age groups are influxing a little greater than we thought they would at this point, which is disheartening, obviously. So that's what we're seeing a little bit of right now. We'll see another spike if it holds true in prom season. Again, very distressing, but the bigger one there will follow right along in March, April, when the comprehensive assessment scores are done and the testing is complete. We'll see that. As far as innovations, I think the one thing that we recognized very quickly when I took this role as CNO is that we are not a behavioral health facility. We're an acute care hospital. So leveraging a partner like McNabb to use their expertise and doing something different, building a crisis stabilization unit inside of a hospital. We had an area that wasn't used, not typically done for behavioral health, but it actually worked very, very well. I think if you look at 2 things, those are the things that we did. We're leveraging who we partnered with and then building something totally different.
Can you share a little bit, having it on the 4th floor of the hospital, what does that look like? What are some of those hurdles that needed to be addressed?
Well, first of all, it's Helen Ross McNabb's facility. It's in our building, but it's theirs. So that was the first hurdle, was letting our staff understand it's not our program. This is Helen Ross McNabb. It's their floor. It's theirs. So very few of our staff have access to that area. The exception, because they are in a hospital, we have to be able to respond to emergencies, to disaster, to code. So we do have that access, but it's very limited. So doing it that way, having that unit that is literally an elevator right away from our ED, and then working so well with our crisis walk-in center that actually started before we opened, so that they're feeding kids there. So if you ask what I think has made the biggest difference is the number of children they see at the walk-in crisis center that they can funnel to outpatient services or to the CSU if they need it, as opposed to coming to the ED.
That's phenomenal. Hopefully other states, and I think you mentioned that there's some other states that are replicating this. What are something that you would like to share with them from the start of the process?
I think from the very, very start, there was a lot of hesitancy about how was it going to support itself? What was it going to do? And from our perspective as a hospital, it didn't matter as much because we're already covering those costs in our ED. So if I can take those children out of our emergency room, I think also leveraging grants from SAMHSA and other places that see something different and are willing to experiment and try and show data that made a difference. So our governor has signed this year in our budget, there will be 2 more walk-in crisis centers and CSUs that will be funded from the state, one in Middle Tennessee, or Middle Tennessee and one in West Tennessee. So Nashville and Memphis. So there'll be 3 of them. So we're working with those, trying to help them see where did we do things that we would have done differently? What could we do better? And also we're looking now, we're working with McNabb at, okay, how do we loosen up some of those restrictions that they've got of what they'll accept to try to continue to decompress. So I saw something in chat, has it licensed? It's licensed through McNabb. It's a behavioral health unit. It's not part of the hospital. That was one of the other hurdles, was making sure that everybody knew it is not part of the hospital. But you still, from fire code and all those things, we still have to meet hospital standards. But licensure was McNabb. It's the mental health piece. The nice thing, I'll say this for those of you who are familiar with hospitals, when Joint Commission comes, it is not a surveyable area under Joint Commission because it's not my license or tax ID number.
Well, thank you so much for hopping on with me, Ron. Please take a look at the article. Thank you.
Thank you both so much. Really incredible to hear about that work happening in Tennessee. Just a couple of reminders as we come to the top of the hour. The latest episode of Moving America's Soul on Suicide is out. We really encourage folks to share the link with your network. We want to make sure that that's available far and wide. So please grab that link from the chat and share via social media with your personal network, etc. Next slide. We have a couple of great episodes coming up in the next few weeks. Next week, join us for a conversation about hiring peers with a criminal justice background. We know this is a perennial topic for folks, and we're really excited to revisit it here on the Jam. Next slide. And then the following week, 2 weeks from now, we will hear from Stacey Owens about service members, veterans, and their families and crisis services in that space. So thank you all so much for joining us today. Thank you to our presenters for a fabulous conversation. And we look forward to seeing you here, same time, same place next week. Take care.